Welcome to the Repro Files, where infertility meets injustice and nothing is off limits.
We're two nurses. We're certified reproductive health advocates, and we're here to tell you everything they didn't.
From the broken systems to the heartbreak left behind, we're here to connect the facts, the policies, and the pain.
Because silence isn't safety, and we're done being quiet.
This is the Repro Files.
Infertility, injustice, and all things nobody warned you about.
Hello. Welcome back, everybody, to the Repro Files. This is the podcast where we talk about infertility, injustice, and all the things no one warned you about. With me is my lovely host with the most, AnnMarie.
Yeah, today we're really excited because we have someone with us who represents a very specific kind of hope in this space.
Yeah. And if you've spent any time in fertility forums or support groups or any exam rooms in Rochester, New York and beyond, you know Dr. Chang.
I did general studies for about.
Dr. Chang is a DO, a reproductive endocrinologist. And as we said, he has a particular dedication to patients who are told that the odds are stacked against them. So Dr. Chang, welcome officially to the Repro Files. We're so happy to have you.
Thank you. So I guess I'll tell you a little bit about myself. So, I was a osteopathic medical student many years ago. And, I guess we'll take a second here to talk about osteopathy, which is something that maybe some people don't know about. So they're basically two branches of medicine inside the United States. There's allopathic medicine, or as you know, MDs. And then the GOs, we practice a branch of medicine called osteopathic medicine. So distinction is that a historical one where there was a man named Andrew Taylor Still, who basically was an American MD. He was trained in Europe. And then when he was in the United States, this is in the early days, founded a whole new branch of medicine, essentially after he became disgruntled with Western medicine. I think the story was that his son had contracted dysentery or something, and at the time they didn't have antibiotics, so they treated him with what they had available, and his son still died, and then that's when he became disillusioned. So he studied Eastern medicine, and some of the osteopathic principles actually come from some Native American medicine as well. It's very interesting. Incorporate that into the Western medicine and invented what he called osteopathy. That was the beginning of osteopathic medicine. The first medical school he opened was in Kirksville, Missouri. It's a DO school. And then the one that I went to in Des Moines, Iowa was the second DO school. So I went to a very old medical school as well.
Said though, tell us more about Eric, the person. I know you have young children. Tell us a little bit more about like before fertility or beyond your role as a physician.
Currently, I'm a fertility doctor. I did my fertility fellowship in New Jersey at a place called the Cooper Institute for Reproductive Medicine, a wonderful place. And then after working for them for a year, I came to CNY Fertility. So I have, a background of doing general obstetrics for 7 years. And I kind of built my family along the way. When I was doing OB, I got married. I have 3 children. One is 14, one is 12, and one is 7. So I have quite the span right there.
You do. Connor, welcome to the Repro Files. You're the first young one we've had on the show. Welcome. We're happy to have you. No, but it shows how dedicated you are, honestly, spending time with us today. Well, AnnMarie, tee it up. Get Dr. Chang with your first question.
So, okay. So we're talking advanced maternal age, which I agree. I do not like that term, but it is way better than geriatric pregnancy, because when I think geriatric pregnancy, I think of like an old lady with like gray hair with a cane and walking around pregnant. So,
yeah, like Golden Girls, like a pregnant Golden Girl. Like,
yes,
that is what.
And then like even AMA, when I talk about it to my own patients, I always say, well, it's this term that they say advanced maternal age, but they're saying that to people who are 35 years old. And I don't consider that old, but anyway. So one of the questions that I want to ask you, Dr. Shane, is what is your approach to women who come into your clinic who are, let's say, age 44, 45, or above, and they want to use their own eggs? What does the conversation entail when you have that?
So, when people at CNY patients have a consult with me, I normally go straight for full disclosure because it's one of those things where I don't want to set unrealistic expectations for them. And that's a little bit of education too. I think that although you're saying that there's a kind of like a bad stigma associated with that term, some patients don't know about it actually. I guess so. So there's a real mixed bag. Some patients do, some patients don't. And what I find actually is a lot of patients, CNY is the sixth largest IVF center, so it's a large catchment of patients. And then when somebody is referred to me, if they're willing to wait long enough to talk to me, which can take a couple months, they're usually primed already in that regard. So in other words, they know that they're a difficult case for something like that. So I take advantage of that, and I really just want to introduce them the idea of advanced reproductive age, and I just tell them that I'm going to be as transparent as I can with them, and I want them to understand what they're getting into if they want to do a treatment with me. I think that's very important.
Mhm.
The patients that I have already they failed medicine at one of the bigger, and we may be at CNY their last chance to try treatment because maybe they've run out of whatever things they had stashed away for their fertility treatment. So that's the last thing I want to do is I want to treat them without having them understand what their odds are with the parameters that they give me. I mean, that sounds a little dry, but that's how I open up every
Mhm.
single consult on a new patient that I have because I want them to know, hey, look, you're 45 years old. Most of your eggs are not the full complement of DNA now. Maybe 98, 99% of the eggs are bad now. Do you understand this? Yeah. And then a lot of times, actually, the patients don't know that. They come in and they're 44, and you tell them these kind of numbers, they are shocked. So that's one of the where they spent $30,000 at some other place last year, and they didn't came out without a baby, and they didn't know the odds were that bad, right? And they're already 45 when I'm talking to them. So I don't want to throw some other place under the bus, but still, I just have to be as transparent as possible. So honestly, that's what I do. And I've never had a patient say, oh, those odds are bad. I'm not going to continue. Most of them, if you're honest with them, then they'll be honest with you back. And at that
Right.
point in time,
That's
they've already made an appointment with me and they've waited a couple months or something, I think, are committed to this kind of thing. So they usually move forward and want to try some kind of treatment plan, even though I tell them that.
I think it's fascinating that you mentioned when you were talking about the background of osteopathy and how it was founded out of a frustration with the regular path, not looking at all the things, right? So it's fascinating to me that your DO training much shaped the way that you look at infertility and how you treat it. So curious, when you mentioned you did general OB for 7 years, when did REI become the thing you were focused on? How did that happen?
Well, so my pathway to becoming an REI was actually quite interesting. I was an OB. I'm not one of these people that didn't like it. I actually was in the Camden community and delivered hundreds of babies and did C-sections, hysterectomies, all of that sort of thing. So I was a well-established OB inside Camden and really happy with that role. So I worked at a place called CamCare. When I was doing OB, I stayed in the area where my residency was, which is that Camden, New Jersey area. And when I was a president, we did have a fertility segment. And so I became familiar with the REIs that were associated with Cooper University at the time was Dr. Jerome Keck and Dr. Young Cho. So the thing is that Dr. Cho is very old fashioned. She kept my name inside a little 3x5 Rolodex that she had. I think she put every resident's name inside this little Rolodex. She was all paper and stuff. It's kind of interesting. So then when they actually started an REI fellowship, they thought about me select as their second fellow. And I feel very honored about that. So I was already a practicing OB when Dr. Cho called me up on a Saturday night and said, "Hey, Chang, do you want to become reproductive endocrinologist?" That's what she said. She said that to me on a Saturday, and I didn't know what to do because when you're a fellow, you're using a resident salary essentially. I already had a child at the time, and we had to go back a little bit. But the thing is, my wife was already working for the state of New Jersey full time, so we talked about it a bit, and we decided to scale things back. Maybe we could live off of her salary for a few years if she wanted to get me out of OB, which was the deal there. OB has a lot of long hours
Yeah.
involved. Waking up at 2 in the morning to run in to deliver the baby, that kind of things. So it was a trade-off for her. It wasn't completely unselfish. She got me out of OB into fertility, and she had me around more. I have to say that it's very interesting though, having that component where I was actually practicing OB for years and then going back to fertility because I can see it from both sides now, right? So I see things from
Yeah.
fertility's perspective, but and I see things as a DO too, but I see things from what an OB is like when you're a general OB and you inherit a patient who's pregnant 8 or 9 weeks and they have diabetes or they're 47 years old. I am sensitive to the problems that the OB has and the thoughts that they have when they inherit such a difficult patient from the fertility doctor. So I think that's a good thing. That's made me a little more um, palatable to the general OBs in the Buffalo area. I hate to say that, but
Absolutely. You build a lot of
it's
goodwill.
interesting.
No, I mean, a lot of OBs are afraid the fertility doctors will steal their patients or something, but they're like, no, no, Chang's good. He'll send him back to us.
Yes, yeah. So I
That's
think
awesome.
overall, all the thing as anybody who has life experiences that feed into what they're currently doing, I certainly think that everything that's happened to me before has has served me well in taking care of patients today. These things where you don't think about it at the time.
So, Dr. Jane, one of my questions was being a DO a little bit different than being an MD because you're looking at more of like the whole entire person, more of a holistic approach. In the fertility space, there is a lot of alternative ways. We have acupuncture. We have patients that do a lot of different things. What
A
would you
lot, yeah, a lot.
say? Yeah, yeah. What would you say there's an alternative type of medicine or alternative practice that you would tell your patients to avoid?
So yes, there are a lot of alternative medicines out there for fertility for sure. And again, I think that being a DO that does attract certain patients to me as well. That think that I might be a little more sensitive than I am. And overall, I think most of these treatments may or may
Right.
not help them in their fertility journey. Everything we say from here forth, it's going to be controversial, right? Because there's not a lot of data, and as you know, inside our field, a lot of REIs are very specific and kind of eccentric, very smart, kind of living in their own beliefs. A lot of my old professors, that kind of thing. Probably the same way, I guess. So everything that I say moving forward is it's just me. If anybody's watching this video later and wants to have a beef with me, they can contact CNY and they can email me. And I'm happy to talk. Okay, so because what you just asked was a very controversial question in our field. I must say the one supplement that I think that you have to be careful with is DHEA. Yeah. And the reason is that if you take this medication and the prescribed amounts are often very aggressive, I think that a female's hormone levels be too androgenic and that may harm the
Mhm.
egg quality. If we're doing fertility medicine, we're trying to get them pregnant. So that's very important.
Well, I love that you are very honest about that because that's a supplement that I see a lot of patients coming with or asking
They're on
about.
it.
Should I be
They're
taking
on it.
this?
They're definitely on it. And so it's one of those things that I don't want to tell them not to take it. The
Yeah.
little ladies that have like the real frail body structure and they have a low estrogen, they probably need it. I'm not saying it does help their quality. Okay, so all I'm saying is
Right.
it may help their quality. So all I'm saying is that should be taken like a little bit carefully. That's all I'm saying. Have them make an
Yeah.
Well,
appointment.
No,
from
I think that's an honest answer, and I think
yeah.
that's what people want, and people want to have that conversation and be open and honest, and I appreciate that definitely out of my doctor, and I think that people appreciate that.
Well, and
Yeah.
from a clinical standpoint, I love that you brought up Dr. Chang. There's not a swath of research about this. And because medicine gets things wrong when we only focus on statistics, like when statistics become the whole story, pregnancy, childbirth, and a live birth is quite a miracle. When you try to help somebody who can't have a baby try to have a baby, you realize how unbelievably miraculous it all is anyway. And so what do you think medicine gets wrong when they make statistics the entire story? And again, we'll put this in the show notes that these views expressed are those of Dr. Eric Chang himself. Any beefs shall be taken up with him offline. But we do really try to focus on things from a different perspective, and our listeners are used to that. And that's why we asked you to come because we want you to tell us the truth about where do you see that medicine gets it wrong when it focuses too much on, well, there's no RCT and just more of a pragmatic approach. So from a clinical standpoint, you mentioned that, in our field, it can be controversial to offer things that don't have a strong statistical backing, a bunch of randomized controlled trials that prove it. But where do you think medicine gets it wrong when when statistics become the whole of the story instead of part of it?
I think that the statistics are important. I don't want to say that they're not important, but overall, I guess it's a little bit in our field, we have a tendency toward focusing on the statistics too much. I'll give my old fertility fellowship a little bit of credit here that it's one of the first things that they impressed upon me is that we have to take care of a patient as a patient. The patient's not like a laptop, you know what I'm saying? So you have to look at the
Yes.
patient and the patient's feelings and what the patient wants to have done and what their goals are and what their parameters are. And those things are very important. You have to consider those things, but the statistics shouldn't be the first thing. You know what I'm saying? So I want to clarify a
Yeah.
little bit too, because when I said earlier that when, how do you open up like a consult, like a conversation, all that, and I mentioned them how poor their chances might be if they use their own egg and all that kind of thing. No, I don't just say that with no context around it. You know what I mean? Like
Sure.
you still have to say hi to the patient and develop some kind of rapport for a minute or two, and you have to have the patient understand that you are trying to take care of them as a person and just help them to achieve their. So that is the most important thing. And then right after that, I'll probably roll into the statistics. But you have to, even if you want the statistics in there as an REI, which they are very important. I think some REIs don't get them across clearly enough, actually. You should still establish that patient rapport first.
Patients, AnnMarie and I have talked a couple of times, and I know Dr. Chang, you and I talked about this at ASRM about how restorative reproductive medicine is trying to infiltrate our field, partially because there are a lot of patients who don't feel like their REI shot them straight.
Right,
Right.
right.
So when we
Absolutely.
don't shoot
Absolutely.
patients straight, it gives way
Uh,
to what are your thoughts?
Yeah,
Well, and
yeah,
let's
yeah.
talk.
I
I
mean,
mean,
I'll say if some of the restorative medicine guys are going to listen to the podcast too, I welcome them to contact me because I am not their enemy. I think that you have a very good point there that REIs might have driven away some part of the population that thinks that we're too number driven. That's certainly true, and those patients might then be tempted to turn towards a restorative medicine, and I think that that it could be a good thing as long as we were all working together. Obviously, restorative medicine, they have a very loyal patient base that needs fertility treatment as well. It's a little bit too much of a dichotomy was developed at ASRM this past October.
no,
Yeah, I think REIs and restorative medicine were really coming from the same place, actually.
listen, that's our show. That's literally the tagline of our show. We should change it. If we don't piss somebody off, we did it wrong, right?
That's great. I
So
love that.
anyway, the restorative medicine guys, please contact me, and I really welcome working with them. Go to their place and speak with them and that kind of
Yeah.
thing.
I love that. You gotta extend the first hand out, right? Like,
Right,
we are all on the same team, our patients all want the same outcome,
right.
and we can bicker over whose is better or whose is more morally correct, or we can go, "You know what? These patients want the same thing," and really, you're absolutely right, Dr. Kang, so many times. We do everything that they want, that they talk about,
We do
but the
absolutely.
disgruntled patients for whom yeah, but some patients fall through the cracks.
I mean, my whole thing is that we have to look at our field and how did we push people into the RM space, just in the fact that we don't want to take on them because of numbers or because of
Yep.
statistics or maybe because we just didn't want to take on, like it there's basically giving them no hope, and sometimes people just need that extra hope, or maybe they just need one more cycle, one more time to do it. And if it doesn't work out, then they're willing to move on to donor or what have you. I think the bee in the bonnet kind of thing was the fact that RRM comes out and they say we're going to find the root cause. That's not what the controversial thing is. The controversial part was that they don't believe that IUI or IVF or anything like that should be used. And
Mhm.
I think one of their first statements was man and a woman, and I think that's what I think got everybody in the field very alert we went on alert, and I agree that is what the full alert I think was. One of the things I always think about is, can we be friends? Can RM and IVF be friends? Can we be friends? I think so. I think
Yes.
each side has to give a little in the fact that, okay, they don't want to do IVF, but don't be coming after us, if we do it, because there are people that need it.
Oh yeah,
Well, and
absolutely.
Dr. Chang, you don't talk people into IVF who are morally opposed, right? Like, I have never worked with an REI that had a patient say that they were morally, ideologically, or otherwise opposed to IVF and that the doctor tried to convince them otherwise, right? We don't do that.
No, I don't do that, but I could see where that might be misconstrued. For example,
Yeah.
there's certain categories of fertility or certain patients that natural method is not going to work very well. And so if you
Right.
look at that kind of thing, like patients that have DOR, the natural method is known to have a very low success rate. Doing a cycle of IVF is going to be a lot more valuable to them than doing like 10 cycles of IUI or something. There's certain, I just think that REIs, some of them are a little bit, they're not eloquent enough to kind of explain the difference, or maybe the REI chooses the wrong words to use.
Yeah, I was really wondering more like if a patient said to you, "Listen, you're saying I do want you to know your best chances of walking out of here with what you want is IVF," and that patient said to you, "Dr. Chang, I am morally opposed to IVF." That would be the end of that conversation. You would not sit there and try to convince her that her views are wrong or say, "You're a bad person if you don't do IVF," or
Well, I wouldn't say that I'm completely innocent of that either. I would say it depends on whether you're talking to the Dr. Chang from 6 years ago to the Dr. Chang from now. As practitioners, as human beings, we change. And I think I've become a little bit more sensitive to other people's needs or a little more polished as a physician than I was
fair.
5 years ago. So it's one of those things where I can think of a couple specific examples. I had patients that were really morally opposed to IVF. I've had one or two of those patients, and it's difficult because you're on the phone with them, so it's not the same as inpatient.
Sure.
I remember getting into a bit of an argument with one of the patient's husbands. Like this, maybe like 4 years ago or 5 years ago. So, but you try not to engage in the emotional side of these treatments, but sometimes you get sucked in, and you sort of
Yeah,
almost can't help it. You know what I'm saying? Yeah. So this is one.
I yeah.
RAIs have never engaged in that kind of thing because I think that sometimes even unintentionally it happens to you, and you realize 5 minutes too late that you're stuck in the middle of something that you didn't want
That's
to be in. You know what I mean? Yeah.
That's a really fair and honest take, and you're
Yeah.
absolutely right. I've never heard a doctor, like, argue with a patient, but it's a really good point that that's not to say that it doesn't happen, and that we are always getting better as people, as providers, as nurses. We should always
Right.
be getting better, so I
But
appreciate that
but but
you
but but but
shared
but, but
that.
what I would say is nowadays if somebody says to me they're morally opposed to IVF. You're right. The right thing to do is to just drop it immediately because
Yes.
the moral practice of somebody is not there. So it's one of those things where I would drop it immediately and go in a different direction. Just try to offer them whatever a treatment that I could offer them that they would be okay with. Maybe I wasn't that savvy about that kind of thing years ago.
How do we take responsibility for our part in how that has developed? Because we do know from a scientific perspective how effective IVF can be. And so
Right,
I think
right,
we've,
right.
yeah, the emotions can get drawn in to be like, what are you talking about? You guys want a baby. Here's the statistics.
Yeah, absolutely. Yeah.
Right. Again, nowadays I probably tend to shy away from that question, but in the right forum, that question might be appropriate, right? Because they may say we might have it, we might want to have a baby, we just don't want to freeze an embryo. And then you have, the Catholic patients I have that will come in. They don't want me to tell anybody that they're going there, but basically they'll come in and you can do, treatment without freezing embryos. You could do a
Right.
retrieve and then and freeze eggs, right? And maybe just fertilize one or two of them and transfer whatever fertilizes. And then you could,
Yeah.
if those don't
Yeah.
work, you could thaw out one or two more eggs and fertilize and transfer those, right? So there's ways to do that sort of thing. You can do IVF without freezing an embryo or throwing an embryo out, but again, even engaging that kind of conversation maybe is not appropriate. It just depends on that couple or that patient, right?
Well, it's tough though, right? Because we're here to educate. We are here to educate. So where does it become education? Where if you understand that the root of the patient's concern, maybe you can help educate them on other options, like you just said. Like, how about
Maybe,
instead of freezing?
maybe, but a lot of that falls back on what we talked about earlier about, treating them as a person and basically getting a good handle when you're doing a consult on somebody. You have to see
Yeah.
where they're at and whether you're going to be able to engage them in that manner.
Yep.
Because you may or may not be
Absolutely.
able to.
Fair. And we got to meet them where they're at no matter what.
So some of the questions that I have, just going back to focusing on advanced maternal age patients. So I've been in, different clinics and they have different protocols about their AMA patients. So one of the things I've noticed is that different clinics and different practices essentially clear their patients to move forward by making them do certain things. I've been in clinics where, oh, you have to see a maternal fetal medicine specialist first before we will treat you, and you have to be cleared by that person. Or you are over this age, so now you have to go do a stress test, you have to do chest x-ray, you have to do all of this to see a cardiologist. What are your thoughts about essentially clearing patients for pregnancy? And you yourself being an OBGYN in the past, what do you think is the best practices for these advanced maternal age patients?
There is what the standard in medicine is, and then what we choose to do, which may or may not always jive with. In order to get somebody pregnant, obviously we know that pregnancy is a high risk state. So at least theoretically, statistically, when a woman's above a certain age, like there's for all these things to go up, like MI and
Right.
I'm saying, at least theoretically, speaking from a scientific perspective, I think it's fine to be very conservative and to demand like an MFM clearance for pregnancy before you treat them. I think that that's okay. Is not what I do every day at CNY. And that might sound funny just because I'm treating a lot of advanced age patients for Dr. Kiltz at CNY. But all I'm saying is that again, we'll harken back to that earlier conversation about treating a person rather than a number. And this kind of harkens back to the science too, right? Because if you want to be completely honest about these things, when four different 45-year-old women present to you, they're not all going to have the same cardiovascular risk. There are so
Yes.
Right.
many things that affect that. There are, if you, these four 45-year-old women, they all have carry different histories. Like some of them are obese, some of them are not obese, some of them have a high cholesterol, some of them have a low cholesterol. Sometimes the LDL is high, since the LDL is high, HDL is high, right? Some of them exercise, some of them don't exercise. Some only do cardiovascular exercise, some only do weightlifting, right? Yeah. A patient is a summation of their ADLs. And so these four different 45-year-olds have different risk factors. Each of the four of them, their risk of stroke is different. Each of the four, their risk of heart attack is different. So each of the four of them, their risk for illnesses with pregnancy is different, right? Biologically, if a person's
Really?
so in other words, if I'm going to sit there as a fertility doctor, I'm going to go put the fertility hat back on now, not the primary care hat back on. I'm just saying that who am I to sit there and say that this 45-year-old needs clearance and needs an EKG and needs to see an MFM doctor before we get her pregnant versus the next 45-year-old? So I think part of it is simply looking at the patient as a whole, using your common sense, using your training, and saying this patient needs clearance before pregnancy, whereas this other patient may not, even though she's 46. She may not need clearance if she's healthy in many different ways and just had a baby last year. Well, if this patient was 45 and I did a transfer on her last year and she went to term and delivered and everything was perfect and her cholesterol is perfect and she's healthy and she runs marathon stuff, why can't I transfer again the next year, right? I mean,
Absolutely.
do I need to get her have clearance again and to do it again?
Right.
There's different shades of this. An intelligent MFMer actually would probably agree with me on these things too. So basically, the way I look at clearance is I think that, it's just me, it's Dr. Eric Chang, okay? Okay, so all I'm saying is
Yeah.
I look at the patients and I try to decide whether I think they need clearance or not. That's the most honest answer that I can give. What I do is I look at each patient and try to decide myself. And every doctor has their own experience, right? that they bring to the
Yes.
table. And so if a doctor wants to make sure everything is super tight before they take a patient on, that's okay. Yeah. But I would say
Yeah.
that if you're a patient that is looking to get cleared and you can't get cleared and you can't get cleared by your doctors, maybe that doctor's not for you. Maybe you need to talk to another doctor to get another opinion. That's all. That's all I'm saying, you know. Yeah.
Yeah.
Well,
No,
and
I
and
I
not
I think that's good.
arbitrarily putting it based on age, because that's what I'm hearing you say. It's kinda silly to be like, on your 45th birthday,
Yeah.
all of a sudden,
All of a sudden
everybody
you're,
is
yeah, right, right,
yeah,
right.
of
Yeah.
equal risk of these things, and if it were that simple, then we wouldn't need doctors, right? We could use a algorithm and we wouldn't right? But that's not who doctors are because doctors, nurses, we have to put the whole picture together.
And with AI taking over, that may happen someday.
It might, but for now, we still have doctors who have amazing experience and, you know, the ability to help steer us away from that.
No,
That
I
because
think
it is arbitrary in some ways, and yet in other ways, like, I don't think you could say one way is right or wrong. I think you have to decide, like you said, Dr. Chang, how much do you wanna look at the whole picture versus just, like, CYA and call it a day.
yeah.
Right.
I agree. Like if you were gonna have presented in front of you 4 different patients with 4 different diagnoses and they all look different, they all have different exercising routine. I don't think that there should be a blanket. We have to do this, this, and this before we'll even treat you. So I agree with you. I totally think that you have to look at each one as an individual and decide from there.
Right, right. And remember, all doctors, they have their own licenses, each one of them, each one of
Mhm.
us. And so I'm just saying that they do what they can to protect their license. So I'm not saying that the next doctor is not allowed to ask for the stress test and all that. They can if they want to, you know what I'm saying? Yeah.
Right. No,
But,
yes.
that's not my approach.
Oh, I agree. Where do you see when you're in a consultation with a patient and you're kind of gauging them, how do you approach the topic of donor egg? Do you get a feeling from them before you approach it? What is your approach to discussing donor egg with these patients?
That's a good question since I talk to a lot of advanced stage patients. So it's one of those things where I have to talk about it just because it's part of our field, a part of the advanced stage. What I found over the years, it's a very hot topic in our field, right? Yeah.
Yeah,
And there are people that
very.
have like personal opinions about that for or against. And then there's like people like the religions, like it's really, I think a lot of my Muslim patients, they just can't use donor eggs. The imam at the mosque tells them they can't use them. There are, different shades of that. So what I usually do is I kind of have a canned response for that. So when I'm talking to a patient, I've established, they obviously want to see me for own egg IVF the majority of the time, and see what I know or what I can help them with. I try to establish that with them first, but somewhere in the consult, I'll try to insert a little, by the way, I just want to mention this one time. I'll never bring it up again, but just so you know, we do have donor eggs, just so you know, and it might help you if we fail with the other treatments. Done. Period. So,
Yep,
so,
that
so, 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 if I insert that couple sentences in there, sometimes they're responsive to it and they want to know more, and they'll let me know. Most of the time, they'll tell me that they've already been told that by 2 other places they're not interested, and that's fine. But at least you let them
but
know that that the door is not closed there. CNY has so many modalities that are available. It's one of the things that even if I do work with them for a year and do 2 retrievals, 3 retrievals on them, and they don't work, they might circle back and change their mind sometimes. You know what I mean? Yeah.
well, and it's
So we
our
leave it open.
job to make sure they know, and I would say that to patients too, Dr. Chang. I would say, "Listen, you can I'm gonna say this one time, or I'm gonna say this sentence, you might be like, 'Elizabeth, you are nuts. This is the craziest thing I've ever heard, and if you think that, we will just keep on going like I never said it. But I want you to know that there is this thing called donor eggs and da 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 da.'" And if they like shake their whatever, but you do like I feel like it is partially our responsibility. Again, this is where we do differ from if AI is the future of healthcare in terms of like delivery. We differ because we do have that sort of duty to the patient at the end of the day, not to their anything but just them and what they came in for. And so what do you think, Anne Marie? Because I definitely felt like I would say that very sentence, like you can tell me to never bring this up again, but I just want to make sure you know.
Yeah.
So that's interesting, Elizabeth. You have that same kind of you have a little canned thing that you say about that too.
Yeah,
Huh? Yeah,
yeah,
interesting,
yep.
right? Yeah, yeah, yeah.
Yeah, just because I do think, like, it's one of those things that you've read the room before, you know that's a hot topic thing, and at the end of the when you chart, you discussed all risks, benefits, and alternatives. Did you? If they you just know, like, they might be do they look Muslim? Did they say they were Did they say that they believe in that principle of that we have an obligation to allow the patient the full breadth of choices, the full breadth of choices. Like, is there a patient story that has stuck with you that sort of explains why you keep doing this work? It obviously takes a lot of patience and a lot of time, and a lot of patients, what they think it's going to be a one and done thing, and that the ongoing patients who really struggle are a lot of work from a lot of different perspectives. So, is there any patient story that sticks with you why you keep doing this work?
That's a good one. A good one is a patient that I believe that she's a school teacher or something that is out in New York City and as advanced stage. So she was about 43, I think, or so when she started treatment with me. And so it's a phone consult I had. I've never seen her. I had a consult with her and her husband. It went well and told them that, and she wanted to do this thing where she wanted to test the embryos. And I was telling her at 42 or 43, whatever, that, you may not get any euploids and that kind of thing. And she understood this and started doing cycles and banking embryos and testing them. Yeah. So that very tedious thing, that she did. And she did this. And then I got a call from them, say 3 or 4 months into the treatment, saying that they got a euploid embryo. And she was so excited. And then we revamped the technique
Wow.
and got one euploid. Then I think over the working a long time, like a year and a half, had ultimately 3 or 4 euploids banked. Really amazing, amazing. So then she stopped, and then we had a consult about embryo transfer, and she wanted to know about protocols for transfer and all that. I made her a nice one, and she transferred and got pregnant on the first transfer. Got transferred, had a baby, really just wonderful. At that point, 43 or whatever she was. So I'm just saying, like, really fantastic experience. And then she wanted a second baby. So they called me for another consult to just see if they needed to redo anything. And we transferred, and she had another baby. I think you know what? She didn't have the baby yet. I think she's like pregnant. She's like 7 or 8 months or something right now, actually. Really fantastic from a few different points of view. Like, she's somebody that's not in Buffalo. I've never seen her face. Just directing her. She's going to a different facility. And
That's incredible though, that that's the one, like, that's something that sticks with you, because we do know that every day, especially if you've ever worked at a place like CNY, which that's how Dr. Chang and I know each other. But, like, there are all of these patients that other clinics are like, sorry, you don't meet our criteria. And they ultimately end up having babies.
they do. They do.
It's against all odds, but it
They do.
happens.
They
And
do.
the fact that it happens is why at least I still fight, kind
Yeah,
of
yeah,
for
yeah,
those
yeah.
patients.
But I'm happy to take care of patients from long distance like that. And then when they actually get
Yes.
pregnant, they're so happy that to have had me as their doctor. That's just amazing, right? When somebody has a baby because you help them have a baby, it's amazing. I used to deliver babies, but I don't know. This is equally amazing. You know what I'm saying?
I'm sure we probably have both cared for her, but there's a patient that comes to my mind. I just saw her picture on Facebook yesterday, 24 weeks. Her bump is adorable. And this couple tried for, I want to say, like 8 or 9 years.
Boy, oh
And they
boy, yeah.
started super young, and I mean, just failed cycle after failed cycle after failed cycle after failed cycle, and for her to reach out to me over text and be like, "We did it," like, I'm even getting choked up
That's
because
that is amazing, right? Amazing,
it's
amazing.
something, yeah, there's something
Yeah, yeah.
so humbling about being able to help somebody. You are hanging out with your sons on a Sunday because you got to have a family, and we get to help people do that, like, how humbling.
Well,
Yeah, sometimes I really can't put into words. Like there are actually too many of them. You know what I'm saying? Yeah, yeah. It's a good
Yeah.
question, but yeah, it's really difficult. And
yeah, Dr. Chang, we really thank you and we appreciate you for being the kind of physician who stays with a patient and sees them through when sometimes it's easier for some people would be stepping back on patients, and you stick with them and help them and continue going forward with them. And we appreciate your time that you that you spent with us today, just because we know that there are other things that you could be doing, and you're doing two things at once, which is amazing. So you were able to spend time with us as well as spend time with your family. And I think that just shows that how dedicated you are to your family, to your profession. And, I can't thank you enough. Thank you for coming on today.
Oh, of course. Yeah.
Well, we appreciate you joining us. We appreciate you guys who have listened and stuck with us. This is super special to our hearts. As you hear, the three of us are very humbled to be able to do what we do and to share more of it with all of you. So until next time, thanks for joining us. This is the Repro Files.